Hi, I'm Wendy Huff, Vice President of Programs and Clinical Care at MGFA. It is my distinct pleasure to introduce Dr. Emmanuel Tiongson. Dr. Tiongson is a part of the Division of Neurology at Children's Hospital Los Angeles as a specialist in the treatment of pediatric neuromuscular disorders. She is a medical lead for the Multidisciplinary Neuromuscular and Myasthenia Clinics in the Division of Neurology. Dr. Tiongson specializes in the treatment and diagnosis of neuromuscular disorders in the pediatric population, including pediatric myasthenia gravis. Dr. Tiongson will be speaking with us today about pediatric MG.
Hi, good afternoon. I'm Dr. Tiongson. Thank you for that introduction. I'm going to advance the slide here. And so I'll be talking about pediatric myasthenia gravis. Just like Wendy said, I'm in the Division of Neurology at Children's Hospital Los Angeles, and it's an honor for me to speak with you today. Our agenda today, we'll just be going over an overview of myasthenia gravis. Though this is a general talk, we'll be going more into pediatric MG, how we diagnose and how we treat it. There's long-term follow-up in pediatric MG that is particular to our population. And then in the current state of our country and world at large, we'll go just a little bit into MG and COVID-19. So what is myasthenia gravis? It's a Latin and Greek root. Myasthenia means muscle weakness, and gravis, back when this was first made a term, it was grave to the people who had it, so it's very severe and grave. So this is termed a muscle weakness that is grave. Here is a picture of the neuromuscular junction. And so this is a neuromuscular junction disorder. This means that in a patient with myasthenia, the muscle itself is normal, the nerves are normal, but the connection between them, or that neuromuscular junction, that is not normal. And we'll go more into the immune part of this. And so this is an autoimmune condition. How I explain it to patients and their parents is that the immune system becomes overactive, and treatments we have for MG are largely to control this immune response. So in kids, there are a lot of infections that can happen, and sometimes the first presentation of MG can be triggered by a common cold or even a serious infection like COVID-19. There are patients who are undergoing chemotherapy for cancer or immune therapy for another autoimmune condition. For example, I just had a patient with diabetes type 1 diagnosed with myasthenia. A trigger can have these people present with myasthenia symptoms. So it's very important, as pediatric neurologists know, to really delve into that family history. Is there a setup for autoimmunity in the family, and is this child predisposed to developing not only myasthenia but other autoimmune conditions that are common in family history and sometimes in the same patient that has myasthenia? So type 1 diabetes, there are families who have older individuals celiac disease or lupus. So here's a picture of what a normal neuromuscular junction looks like. Is the nerve at the top of the picture sends a signal down, and normally that signal is absorbed by the muscle, and then the muscle moves. However, with the immune problem, those antibodies stick to the end plates where the signal is supposed to connect. And so you have an inhibition of that end plate potential, is what we call it. And so the muscle can't contract as you normally would have it do until those antibodies kind of dissipate or are treated with an immune therapy. So that's what I have here on this slide, is that the abnormal antibodies are created by an overactive immune system. And so these immune therapies, now of which we have several very cool mechanisms coming out, can decrease these circulating and make it to the muscle. Mestinon does, or means these signals stay around longer and make it so that they can attach for a longer time, making it so that the muscle doesn't fatigue quite as fast. So it's not an immune medication itself, but it's a very important part of mitigating that fatigue on a day-to-day basis, in a very rapid basis. So that was a general overview about myasthenia, which could be applied to both adult and pediatric cases. But what is different about pediatric myasthenia? And so what we've noticed in the practice of myasthenia is that there is a bimodal, or two age group presentation to myasthenia. So I see the very young patients with this. So juvenile myasthenia is anybody under age 18. And just like in adults, oftentimes it starts with the eyes and then spreads to the body, or you can have a presentation where it is quite severe, requiring hospitalization. The other mode, or the other part of the bimodal distribution, are the older population. So this would be, as in the graph here, there are peaks around the teens and 20s, and then 60 and older, with a dip in the middle age ranges. So we have our adult neurologists treating older individuals, and then our pediatric neurologists treating the younger population. What's nice about pediatric myasthenia is that I have a goal not only to make the patients feel as normal as they can, a normal kid of their age doing normal activities. The other lofty goal that I really shoot for is a minimal manifesting status or remission, because we have pretty much their lifetimes to really treat and really get to a normal function. So this is all tailored to each patient, and I've had quite a few success stories. So I really, really are optimistic around the time of diagnosis for these patients. And so the initial presentations can be quite severe. I've had some patients present, and the first time they had myasthenia symptoms, they were intubated in the hospital and really needed a lot of therapies up front. Or it could be very subtle. I've had some patients present a few months with a drooping eyelid that was just getting droopier and droopier, and somebody noticed. And so there's just a wide range of presentations. Oftentimes it's noticed by the teachers at school, and then more recently with home, online and remote learning, the focus on screens has made it more apparent things that happen with the eyes, like drooping eyelids or blurry vision or double vision. Interestingly, going with the age ranges, I have had toddlers present with myasthenia symptoms, and I have diagnosed somebody. I think the youngest I have diagnosed is 18 months, and there has been younger than that that my colleagues have diagnosed and transferred to my care. And so the issue with treating myasthenia in these very young patients is that a lot of it is extrapolated from adult data, and so it is more limited because of lack of research. And so we try to be on the safer side in terms of the treatment decisions that we make. And then our treatment options are not quite as expansive as the adult population until we do more trials in them. So, and then this is something that is always in my differential when I see a patient very young with fatigable weakness or droopy eyelids. There is an entity called congenital myasthenic syndromes, and these are genetic conditions in which a protein or proteins are missing from any part of the neuromuscular junction. And so a lot of these are babies who were in the ICU after birth and they had trouble breathing, or they were just very weak and floppy. This is not an immune problem. This is an issue with how they were born. And so this is not something that is treated with steroids or IVIG or any of the immune therapies that we will be discussing, but they do respond very well to mestinon, sometimes actually oral albuterol, so not the kind you inhale. It's the liquid version that you actually swallow, or a tablet version that you actually swallow. And there are other ways to treat this as well for fatigability symptoms. And these patients typically do not go into remission, but they get better over time as they grow and go through puberty. And so this is just an overview about what happens in a pediatric myasthenia practice, or what happens in a pediatric myasthenia clinic visit. And so a lot of patients come to me and they're like, wow, you actually know about this condition. And it's nice to have that kind of confidence in me, just because I have experience with a lot of great patients that I've met over the years. And so I just have a few of these animated GIFs or GIFs. In pediatric neurology, a lot of our examination is really observation, because you can't really ask a toddler or a young child to do the same things as an adult can, especially for fatigability and for muscle strength. And so in general, like in that most leftward one, you just kind of see, what can this baby do? What can this kid do? Can they lift everything, or can they not lift everything? Can they climb on things? Can they jump? Can they run? Especially for the eyes, I'm looking at tracking. And so there's a picture of a baby girl doing this great thing on an iPad. iPads, cell phones are my friends. I could use videos to track their eyes very well. And if I want them to look up for a sustained amount of time, I could use a screen. For the arms, we'll do high fives. We'll have them reach for favorite toys, all the sort of things just to get that movement up. And then for legs, I'll ask them to do little kicking. We can do walking, running, climbing, jumping, squatting, things like that for the younger kids. And then for the older kids, when I have cooperation, we do the same things as in adults. And so I can compare these numbers over time. How long can they look up before their eyelids fatigue? What about double vision? Can you see two of my fingers or just one at a time? Breathing testing, counting to 20 or more in a breath. And then I usually do this chicken dance thing, and they literally love it. It's like we're at a wedding, to see if they can do arm thrust and then still sustain their strength afterwards. And then all my patients know I ask them to do squats at every visit, to test that the leg strength and function, so they hopefully get in shape when they come and see me. And so the purpose of fatiguing these patients at every visit, whether it doesn't matter how old they are, I do some sort of fatigable maneuver every time, is to see if the regimen they're on is working well for them. Am I seeing less fatigue? Are I seeing no fatigue? And so if there's a lot of fatigue, I would consider adjustments. And then if there's no fatigue, I would also consider adjustments, but in a favorable direction. Long-term monitoring, all of my generalized myasthenic patients, the pediatric ones, yes, they do get thymectomies, and I actually come up with that up front when I make the diagnosis. And it is a waiting game. I usually see effects a year or two after. Some people sooner, some people later. And so the repeated examinations over time can give me that effect of the thymectomy, mostly in the manifestation of less medication needs over time. And so there are also questionnaires that we have the patients fill out on an at least annual basis. The MGQOL, the quality of life survey, as well as the MG80L, the activities of daily living, kind of track how MG is personally affecting each of these patients. And if the patients can't fill it out, the parents fill it out on their behalf. And so there's a lot on this slide, but as far as laboratory monitoring, this is what I typically do. If the patient's on steroids, I would like to get blood counts. And sometimes I find a concurrent like iron deficiency anemia. And then I go ahead and supplement that iron if they are iron deficient, since that would contribute to fatigue. I also check liver function tests and electrolyte function. And then I usually do go ahead and give a vitamin D supplement, especially if I see the vitamin D level is low. We're seeing more and more evidence that vitamin D does have a role in immune health. And then I also do it for bone health because of fall risk in some patients. I personally like to check the antibodies and kind of track them over time for each individual patient. They don't always correlate with how severe the myasthenia is, but I found that in my patients across time, if they are doing better, their levels are on the lower side compared to when they were diagnosed or when they were going through a crisis. And there are other antibodies that are present that aren't the acetylcholine receptor antibodies, the typical ones. There are times where you're first negative and then years later, just because I checked them, it turned positive, and it could have been just a low level throughout this whole time, and then they converted. There are other antibodies to check for, including antibody called MuSK and another antibody called LRP4. And I also check thyroid because actually this is a very common comorbid or a condition that comes together with myasthenia, are antibodies against the thyroid. So then I'll also check that just to make sure that that's not contributing to fatigue. And so just going on next, I did mention earlier, our choice in treatments in pediatric myasthenia are a bit limited, not only because of research, but also because we have a growing patient. And so I'll discuss initial treatments, what treatments we move to next, and then some side effects of the common treatments that we use. And so in ocular or eyes-only myasthenia, I usually just start with Mestinon alone because this would be the least side effect prone and still give good quality of life to the patient if they don't have drooping eyelids or double vision and they can get through school, then maybe that's all they need. In small children, we do dose this by weight because there are the side effects of stomach upset and diarrhea. Though, as a lot of parents know, most kids have an issue with constipation anyway, so this may actually help with that. It comes in a liquid form. It comes in a tablet form. It also comes in extended release form. So often the progression is with the toddlers and the kids, we start with liquid, then we'll transition to tablets. And then by the time they're in high school, they're asking me for the extended release, or I bring up extended release so that they can go through school and not have to worry about dosing it through the day. In more recent literature, there is evidence that a small dose of steroids may help these patients do even better and may require less Mestinon if you treat a little bit of that underlying immune problem. In generalized myasthenia, so if a patient presents to me with eyes and face and body weakness, anything involving other than the eyes together, I always discuss a thymectomy or removal of the thymus at the first visit. The reason is that that's it's actually one of the guidelines now. And also, I could potentially make them so they're converted back to an ocular or symptom-free in the future. And so I do discuss that up front and get imaging of the chest as well as a referral to our cardiothoracic surgeons. I do start on steroids right at the first visit, low dose in children to minimize the side effects and the side effects on growth. In adults, larger doses are used. So for example, in children, I'll start at 2.5 milligrams or even 1 milligram, depending on how much they weigh, up to about 10 at the maximum, maybe 15 or 20. In adults, you can see doses of 60 milligrams or higher at times. And I don't like to do that because children are growing and I don't want to stunt growth and I don't want them to gain weight unnecessarily. Usually I'll do a combination of steroids and Mestinon first. And then if that regimen doesn't hold them, oftentimes it does, and that's all I need to do with oral medicine. If it doesn't hold them, then I'll move on to more intense immune options, including IVIG or other steroid-sparing options if the steroids have increased, past 15, 10 milligrams, and I'm not getting the control I'd like. Then I talk about other things like a medication called Cellcept, especially in the teenagers, azathioprine, and then kind of on the longer end of like going through all the options, there is rituximab therapy. So this is an antibody given to suppress the antibody production of the immune cells, making that abnormal immune antibody. And then in hospitalized patients, there is a plasma exchange that can be done emergently to really filter out those antibodies quickly if this patient is very sick. And so just going through each of the medicines that we use in a little bit more detail. Just like I said earlier with the picture of the neuromuscular junction, Mestinon helps by keeping the signal from the nerve, so acetylcholine is the name of the neurotransmitter, around longer so that it can activate the muscle. The onset's pretty fast, within 15 to 20 minutes of taking the medication. It lasts about 3 to 4 hours, which explains why a lot of the dosing regimens say take it every 4 hours while you're awake. The same neurotransmitter, acetylcholine, also works to move things through your gut and your stomach, which explains why you can get upset and diarrhea, because things are just a little bit more mobile when you take it. The formulations available are liquid for young kids who can't take tablets yet. The tablets are the same; they're just tablets with the same longevity of effect, so about 3 to 4 hours. And then the extended release tablet is made to be taken once or twice a day. So that could be in the morning and then afternoon after you come back from school. And then you can even split these tablets. So oftentimes for weight-based dosing, or if somebody has GI side effects, I'd split that tablet, so a 30 milligram dose. Or I can even split the extended release tablet, especially if it's brand name, into a 90 milligram dose if they're having side effects. And then the immune part of the treatment that is most commonly used by me, and also research has been done in kids on this, is prednisone or prednisolone. So this is for the underlying immune issue, and low dose is effective with Mestinon in combination. And so the side effects here, I often tell the parents, like, you'll notice a kind of a hungry and an angry child, hangry, if the dose is too high. So you can have increased appetite, weight gain, lability. But at the doses that I use for myasthenia, oftentimes I don't run into the issues. For example, like I use high dose with Duchenne muscular dystrophy. The formulations available for this, there's prednisolone liquid, and that's dosed based on weight. Same thing with prednisone tablets. I tend to use the smaller ones. So there are 1s, 5s, and 10s, and then in the higher ranges, 20s and 50s. Usually I dose this daily. If a patient's doing very well, I'll dose it every other day, probably prior to weaning it off. And then about thymectomy, I do recommend this for all patients I diagnose with generalized myasthenia, so anything in addition to the eyes. And so this is important for kids because then I would save their neuromuscular junction from having an attack over years of time if I can take out a potential source of these abnormal immune antibodies. And so I could possibly get them into minimal symptoms or remission. And so in the past, so for example, some of the attendings who practiced, many, like 20 years ago, or 10 to 20 years ago even, because this was made within the last 5 to 10 years, it was 50-50. Like you could do it, you could not. You have a 50% chance that it would work. But nowadays, the current medical literature has actually done long-term studies that find these patients improve up to 5 years after getting a thymectomy. So it is really scary to think about surgery for a kid, but it would really make a large impact on their lives in that they won't have these fatigable symptoms, or even if they still have it, it won't be as severe and won't require as much medication. This is a treatment that I use quite often in the pediatric population because I'm limited by the immune therapies I can do. IVIG is nice because there is a broad immune control. It really works quickly. And there's passive immunity. So people who are on this actually tend not to get sick from a lot of the bugs circulating in the community. It doesn't suppress the immune system. And there's really not a lot of long-term side effects. Most of the side effects from IVIG are related to the infusion itself. So having maybe a headache, a feeling of fatigue, a few days after is a common complaint that I get, but then they feel amazingly good in terms of their energy until the next dose is due. There is a nursing requirement, so this could be either in the hospital or in a home infusion setting. And this is based on weight as well. So a younger kid would have a shorter infusion than an older one. And some teenagers want to do it in one day. Some patients need to divide it into 2 days, up to 4 days. I usually start at once every 4 weeks and then move up or down in 2-week intervals or 1-week intervals, depending how the patient's doing, to see, what is the interval that they can tolerate. For some of the college students, we try to push it out as much as we can, just so it doesn't interfere with their studies. And so why IVIG? I do tend to use it because it acts so quickly. And then if there is an allergic reaction, I can discontinue it really quickly as well. And so this is a nice alternative to other chemotherapeutic agents, such as rituximab, and actually CellCept is also a form of oral chemotherapy. I like the less long-term side effect profile, and this could be limited by IV access or tolerance of IV access. So actually, some of our patients do get ports if they have IVIG access issues or peripheral IV access issues. And then in contrast to steroids, IVIG is weight neutral, so it doesn't affect the weight. It doesn't make you emotional, and it doesn't affect the growth trajectory for patients. So I try not to push the steroids too high, and if I do get to a higher dose, then I'll talk about other options, including IVIG, including other oral medications. And so this is just a kind of a rundown on what I usually go through on subsequent clinic visits. Like, do you feel a difference when you get it? When do you feel it wearing off? Do you feel normal before and after you get it? And so with each frequency of the dose change, I'll wait 2 or 3 cycles, whether it's 4 weeks, whether it's 6 weeks, or 8 weeks. And then the eventual goal is to not continue on IVIG forever. The eventual goal is to wean it off so that you don't have to go through infusions. Though some patients do like to stay on it because it gives them a sense of security, like every 10 weeks, every 12 weeks. Sometimes that's all it takes to keep the immune system under control. And then these are the other treatments in pediatric myasthenia. The CellCept that I talked about before, it does take up to 6 months for you to see a real effect of it. So sometimes you don't have that time to wait. Sometimes you do, especially if you're cross titrating or increasing something while you're decreasing something else. The biggest side effect is that there are burst effects associated. So I asked my female teenage patients on this to be on birth control at the same time, which is a conversation in itself. There is azathioprine, which is commonly also used in adults, and that also takes some time to work, but does help in reducing steroids or getting off of steroids. There are IV infusions, rituximab, for the more severe cases to really take away the memory of the abnormal antibodies from your B cells. And this is specific for the MuSK type of myasthenia. And then there are research medications that are actually approved in adults already, but are getting into the pediatric space, including eculizumab, also known as Soliris, and then efgartigimod, which is approved in adults now, and hopefully will be approved for pediatrics soon after more clinical trials are completed. And then social considerations in pediatric MG. I always think about, are you missing too much school? Are there ways for me to space this out so you don't have to have so many infusions? Or can we do it home infusions so you can have it on weekends or after hours? In school, having an individualized education plan, 504 plan for the times of fatigue are really helpful. So for example, not doing the timed mile in PE classes, having something called adaptive PEs that adapts to the kids' abilities. Additional time to take tests. So for example, I have a college student who really needs 1.5 times the amount of other than 1.5 times the standard time because her eyes tire out if she doesn't take a break. And then ways to get to class, like is there transportation? Can they have extra time? How about a key to the elevator? Things like that. And then mental health needs. It's a chronic condition. And because kids deal with this so early on in their lives, there is a risk of feeling like they're the only one, like they're isolated in their condition, as well as anxiety and depression. Because of what they're going through, but maybe not their peers. And so we do offer, as part of our multidisciplinary care, which I'll get into a bit, social work services, mental health care services, and then organizations such as the MGFA are so valuable for families to connect. And so we, in our clinic at Children's Hospital Los Angeles, we have a multidisciplinary clinic for myasthenia. We try to see patients in a multidisciplinary clinic in that they visit with multiple specialists in one day, at least once a year. So an annual kind of comprehensive visit with visits in between. And so we have neurology, PT, OT, dietitian, social work, and nurse care management once a year scheduled. And so we want to we maximize the quality of life for all the patients that go through our clinic. And so here are the people on our team. We have the neurologist. We have our nurse care manager that knows all the patients really well, a physical therapist, an occupational therapist. So physical therapy and occupational therapy actually come in together and talk about strategies for energy conservation, as well as how to modify activities, for activities of daily living so you don't tire out every time you do them, and strengthening and conditioning. We have a registered dietitian because being on steroids is hard if you are on steroids, and then moving a body that is heavier is also more fatiguing. So it's really important to keep that healthy weight, healthy diet. And sometimes this extends to the family, and the family becomes healthier as a result. We have a clinical social worker who helps with mental health resources, also resources on connecting with other patients and families with myasthenia so that they don't feel alone. I have a dedicated nurse for communication with infusion, home infusion companies, prescriptions, if equipment is needed, like a wheelchair, getting that done. And then I have also a dedicated person for my authorizations because that is really important in this space. And so here is an example of one of the clinic schedules for one of our clinics, is that we'll start at 7 in the morning and at around 12 in the afternoon, and in 30-minute blocks, the patients will see everybody in that vertical row. And then we all have a team meeting at the end to discuss the patient and kind of wrap up on their care. And so we do refer to MGFA, and we have a lot of the educational paper resources as well as the online resources. And then we are also a partner with the MDA. And so we have those resources as well. And so lastly, myasthenia and COVID-19. In summary, what a lot of these consensus statements are saying is don't stop what you're on if you're already on it. Consider switching out of the hospital into a home setting to reduce exposure. Still practice social distancing and precautions because of the infection risk with myasthenia and risk of crisis. And then everybody, and I've been doing this with everyone, is encouraging all my patients with myasthenia to get the COVID-19 vaccine because actual COVID-19 disease has triggered myasthenic crisis, or sometimes is the first presentation of myasthenia in some patients. And then in summary, the medication choices I make in pediatric MG, I always consider the side effects and the effects on growth. So it's very dependent on the age of the patient. I use IVIG quite often because I don't want these kids to have the long-term side effects with high-dose steroid therapy. So I use steroids at a more reasonable or lower dose. There is a higher chance of remission or minimal symptoms in pediatric MG, and that's always a goal of mine. I always recommend thymectomy if symptoms are generalized, and then I treat the patients with a goal of feeling like a normal person. And I don't think that's too far to go. So thank you very much. This is a picture of my team at Halloween. We just had a Disney theme that year. But thank you very much, and now I can take some questions.
Dr. Tiongson, thank you so much for your time. We really appreciate your expertise. We do have a number of questions. We'll get to as many questions as we can in the time that's left, and certainly we can have you address any questions that aren't answered, and we will send those out to attendees after the event. Let me start with thymectomies, and you've mentioned it several times in your presentation. Can you give us a sense as to really how successful thymectomies are for adolescents? Is it very successful, somewhat successful? Do you have a percentage at all in mind?
So yeah, it's hard to say without actually like going through the numbers of patients in my clinic. I would say at least over 50 to 60% I've seen some sort of favorable response. It's not 90 to 100 like I'd hope. So I would say it's manifested mostly in reduction of need for medications or reduction in the frequency of IVIG. I've had at least I could count more recently some patients that have completely weaned off of IVIG and are really not infusion dependent at all. So I would say maybe upwards of 60%. So not great numbers, but still something that I like discussing with patients because at least we don't have to escalate after thymectomy most times.
Okay. And did you say that extended release Mestinon can be split?
Yes. So I didn't think it could be because it is an extended release version. It works better with the time span brand name Mestinon, but I've seen it done also with the generic one.
Excellent. The next question is QMG usable off the shelf in the adolescent population?
Actually, I think so, actually, yeah. If you have a good cooperative patient, I think we can use the QMG. And actually, I've been using a QMG as part of research studies, and I have an adolescent patient doing that.
Great. The next question is, have you switched any of your younger patients to subcutaneous IG?
I have not. So I had looked into it. The current FDA approved indication is for adults with CIDP. So I I've brought it up with some patients. They entertained the idea, but then didn't want to do it. So I actually haven't gone through an attempted authorization process yet.
Okay. This next attendee has a son with Bell's palsy and now a daughter with MG. Since both diseases are neuro-driven diseases, should this person have their third child screened for any neuro issue?
Oh, can you repeat that question? There was a little bit of a cutoff.
Yeah, we definitely heard that. So this attendee has a son with Bell's palsy, a daughter now with MG. And this person wants to know if they should screen their third child for any neurological or neuro issues.
So that's a great question. With Bell's palsy, we're not exactly sure if it's that a totally an autoimmune condition. It is immune in that we think it's an infection or post-infectious problem with a virus. Given this particular scenario, I don't think you need to preemptively screen unless that third child is having symptoms.
Thank you, doctor. That's good. So the next question focuses on the thymus gland. The active thymus gland helps protect children from COVID. Has anyone checked if COVID provides a higher risk in patients post-thymectomy? Is there any logic in delaying thymectomy during this pandemic?
Good question. So I try to explain thymectomy in these terms. So normally the thymus is active as a fetus and an infant, and normally it's supposed to involute and not be active in your older life, like as a child and as an adult. So actually the thymus is important in establishing the immune system, so establishing your B cells, your T cells, everything. And then it's supposed to kind of just go away and become a vestige, similar to an appendix. So taking it out actually is trying to remove that autoimmunity portion of it, because in kids, when we take it out, it actually shows that it's hyperplastic or overactive. So in the pandemic, I actually would think, because COVID is both infectious and post-infectious phenomenon, taking it out would actually be advantageous. The reason to delay a surgery would be if, for example, a hospital is delaying elective surgeries, or going into the hospital is too much of a risk depending on your area. So my recommendation for thymectomy in COVID-19 actually has not changed.
Thank you, doctor. Just a couple of additional questions. One, are there any long-term studies at all of adults who were diagnosed as children and are now seniors? Any research out there?
That's a really great question. Actually, that would be a really great study. I don't think there's been longitudinal from a childhood diagnosis all the way to a senior diagnosis. I've only seen them done, the longitudinal studies done in the age groups themselves. So like follow up in the pediatric age range and then follow up in the older age range, but like within 5 to 10 years. So I think that would be a great longitudinal study, similar to heart disease or cancer risk, to be done in this community.
Great. Two last questions. The first one, is it possible that infants who develop MG symptoms may have been impacted or affected by toxins from the mother, maybe in utero or while breastfeeding, toxins such as mercury? Is there any evidence of that at all?
No, not particularly. So there actually is a condition called neonatal myasthenia, but this is specific to a mother who has myasthenia and then gives birth to a baby who doesn't have myasthenia, but looks like they do because those antibodies cross the placenta. As far as toxins, ingestions, anything that the mother takes in, if anything, breast milk in itself has protective antibodies. So we think that early exposure to breast milk actually reduces your risk of autoimmune diseases in that early period and possibly through your lifetime.
Excellent. And then our last question, is it possible to have congenital myasthenia but not present fully until adulthood in the 30s?
It certainly could be a case, especially if you have a mild mutation. So if you haven't gotten a genetic testing panel, which are readily available for congenital myasthenia, this is something that could present later, though more commonly it presents in the younger ages. In older ages, we think of patients with these sort of symptoms as having potentially something else in their body, like God forbid, cancer, causing an immune response.
Excellent. Thank you so much, Dr. Teagueson. There's some other information about thymectomy on the MGFA website. If you go under treatments and look at the Thymectomy Resource Center online, we also have brochures on thymectomy, so you could learn about that procedure. Again, it's quite successful for a number of different patients. Doctor, thank you again. And for all attendees, remember to exit this presentation and go into the next one. Thank you so much.
Great questions from everyone. Thank you so much.